Good afternoon and welcome to today's webinar on COVID-19 and informal carers, improving care integration for better outcomes. Informal care is quite common to most of us. We've been caring for children, spouses, parents, and other relatives and friends. They may have the flu, chronic diseases, or COVID-19. Informal carers are usually the first to be there, delivering the bulk of the care. Informal carers represent a huge segment of the health and care workforce. Most care for people requiring long-term care is provided by informal carers. That means informal carers have taken care of a particular vulnerable segment of society during the pandemic. Vulnerable to infections and severe progression of the disease, vulnerable to loneliness and mental issues. But informal carers are vulnerable themselves. Did they have adequate personal protective equipment when caring for infected? Did they receive sufficient health system and social support? The pandemic has put a lot of additional pressures on informal carers, a work which is all too often not really acknowledged or appreciated. Who actually cares for the informal carers? Today, we are looking at informal carers from the health system's perspective. And this raises the issue of care integration between informal care and health services. What is the role of communication technologies, welfare policies, mobile services, financing, training, or other measures to better integrate informal care into health systems? What have we seen during the pandemic that works, and what should be adopted more widely when better integrating informal care? My name is Matthias Wismar and I'm the Program Manager with the European Observatory on Health System Policies. I'm your facilitator today and I will guide you through the program and the session. Our keynote speaker today is Stacey Egan-Monos, Eurocarers. Eurocarers is Brussels-based and brings together carers, organizations and research units across Europe to enable evidence-based advocacy to give carers a voice. In addition, we have lined up the following spotlight speakers. Claire Cairns from the Coalition of Carers in Scotland in the UK. And the mission of this organization is that carers in Scotland shall achieve full recognition as equal partners in care. They should have the right to quality services and access to personalized support. And they also should enjoy good health and a life outside of caring settings. Second, we have Giovanni Lamura from the National Institute of Health and Science of Aging, which is the largest aging institute in Italy. It's the leading public institute actually in gerontology and geriatrics, and it's devoted to improve quality of life of older persons. And last but not least, we have Stefania Ilinka. She's a health economist from the European Center for Social Welfare Policy and Research in Austria. And this center actually has a long track record of working on informal care. So we have a very tight time budget, which is a challenge for all speakers, and we need to stick to it to allow for discussion at the end of the webinar. Just 3 things for housekeeping. Please send us your questions and comments through the chat box. My colleague Erica will feed back the chat to us towards the end of the session. We're also going to record the video and planning to publish it later on our YouTube channel. You will be notified. Finally, we will send you an evaluation form and we would like to ask you to fill it in as it is important to us for further developing the webinars. So we call this series now Build Back Better because we firmly believe that we cannot go back to the pre-pandemic old normal, but we need to see how to foster more resilient, more equitable and higher performing health system. Please check out our website, Health Observatory EU, and you will see the program for the next webinar. Before we start with the keynote, I've asked my colleague Erica Richardson to launch a poll on the topic. Erica, please, the floor is all yours.
Hello, everyone, and welcome. So yes, Annalisa, if you could put the poll up on the screen. Just wanted to ask a few questions so we get to know the audience a little bit better. And first of all, we're just curious to know if anyone in the audience is actually an informal carer, until I didn't realize that I was, until I actually did some reading around for this webinar. And the second question is about the provision for informal carers in your country. So how are they supported in your country? Do they get training? Are there support groups? Do they get access to flexible working? Is there any financial support for them? Do they get breaks from caring, sort of respite care as it's known in the UK? Or do you not know, because this is not something that you ever find out about unless you're in that position? So yes, we're just really interested to know what your experience is of this. Thank you very much. Thank you. We'll give the results after the keynote.
Thank you so much, Erica. Yes, exactly. The results will be shown after the keynote. And this gives me the opportunity to invite Stacey from Eurocarers to take the floor and give us the keynote. Stacey, it's all yours, please.
Thanks a million for your kind invitation. I'm very pleased to be part of this panel. As Matthias mentioned, my job is to basically shed light on the situation and needs of carers. Both, I'll start with before the pandemic, and then of course I'll focus specifically on the impact of the pandemic on carers across Europe. We don't have much time, so I'll try to be concise, and of course I'll be able and happy to answer all of your questions in the last part of the session. Everything I'm going to mention now is based on research, either funded by the institutions or carried out by the institutions themselves. So in principle, those the data I'm going to present to you is fairly reliable. Can I have the next slide, please? So first of all, it is extremely important to know that, again, as Matthias briefly mentioned during his introduction, the role of informal carers in Europe is actually central. According to some estimates, as much of 80% of all care in Europe, all long-term care, is actually provided by informal carers. That is, family members, friends, neighbors outside of a professional context. So a majority of them do not receive any financial compensation, and they're not paid, of course, for their caregiving. The group of carers in Europe, and that was before the pandemic, is fairly substantial. So depending on the definition used from one country to the other, according to estimates, we're talking about between 10 and 20% of the total EU population. So it's a fairly significant group. Informal care is a very gendered issue. A typical carer in Europe is a woman between 45 and 75. And last but not least, because obviously given given the context, the economic dimension of informal care is extremely important. According to a report to be published by the European Commission, the value of informal care in Europe is between 320 billion and 368 billion. At least it was the case in 2018. So that's way above the actual budget currently spent on formal long-term care across Europe. And according to the OECD, if we were to try and replace informal carers by care, professional care, that would entail an increase in the share of GDP devoted to long-term care of 130% on average for the EU. So in a nutshell, it's just impossible to replace informal care and informal carers altogether, because that would amount to creating an entirely new long-term care system. And as we already know, of course, we already are facing difficulties trying to sustain the current long-term care system. Next slide, please. Unfortunately, informal care comes at a cost for carers themselves. So many carers face a lot of difficulties in combining their caregiving responsibilities with an active social and professional life. So that leads to people and carers reducing their working hours, so involuntary part-timers, or carers simply dropping out of the labor market altogether. And that, of course, has an impact also on carer social inclusion and poverty rates among informal carers, who also, in addition, tend to contribute financially to the care costs, for their care recipients. So when it comes to the topic for today's discussion, which is, which focuses primarily on health, the correlation between caregiving and both physical and mental health is also well established. Research has highlighted that the stress and burden associated with informal caregiving actually present all the features of a chronic stress experience. So it creates a physical and psychological strain over extended periods of time. It is accompanied by high levels of unpredictability and controllability, and it frequently requires high levels of vigilance. And as I mentioned before, it also has the capacity to create secondary stress in multiple life domains. So access to education for young carers, access to work, as I was mentioning, social inclusion, poverty. So, so as a result, the carer may experience psychological distress, so anxiety, depression, which in turn may negatively affect the physical health of carers. Just to illustrate this, again, based on EU research, the prevalence of mental health issues among non-working carers is 20% higher than among non-carers. I would add to that informal care is also a social determinant of health. So many carers tend to actually disregard their own well-being and neglect their healthy lifestyle. So in terms of diet, exercise, sleep deprivation, and so on. And this is particularly prevalent in the context of high-intensity caregiving, and this is important given the data we have collected in the context of COVID, which I will present in the next few slides. Next slide, please. So when it comes to COVID per se, well, unsurprisingly, the crisis has done nothing but exacerbate the pre-existing challenges facing carers, so everything I just mentioned. And the policy responses to the pandemic, and in particular the lockdown measures and the reallocation of care services to patients with urgent needs. Well, that means, carers are more isolated than before, and they've been deprived of many of the tools at their disposal to maintain, let's say, an acceptable balance between the social, professional, and caregiving responsibilities. So obviously, this is a situation which, from our perspective, cannot be sustained in the long run. So between November last year and March of this year, what we have done through our network, so across Europe, is we have collected data regarding the impact of COVID on carers themselves via an online survey, which was available in 10 languages. And we have managed to collect about 2,500 responses. So again, it's fairly, fairly good, at least representative from carers across Europe. And I will now try and present the key learnings from that study. So in terms of the impact of COVID on carers' personal and caregiving circumstances, this slide shows you the aspect of carers' life which have been most impacted by COVID. And as you can see, social network and participation has been, the most severely impacted dimension of carers' life, just like, all of us, I would say. But second and third on the list, and that's the most important aspect, or at least the aspects I wanted to underline today, The quality of life, so well-being, and mental health and psychological state of carers come second and third on the list. So that, you know, that's a pretty significant and pretty severe impact of the crisis. Another aspect emerging from the survey is that carers tend to provide more care than before the crisis. So a majority of carers report that the number of weekly hours of care provided has increased as a result of the crisis, on average by 17%. I would like to again stress the fact that the average number of weekly hours before the crisis was already at 46.6 hours, which was already pretty high. So we're now at 54.5 hours per week. So again, that's something which is clearly not sustainable in the future. In addition, not only more care, but more intense care as a result of COVID. So in particular, at the top of the list, emotional support for more than 60% of respondents, but also trying to deal with remote communication, so remote caregiving, and also practical help in person and care coordination. So how to cope with the fact that suddenly, when available, when in existence, you know, professional care services are not available anymore, or you know, have disappeared or have been drastically reduced. All of these aspects, again, another interesting aspect, all of these aspects primarily affected female carers. So women have been more affected by COVID. Female carers have been more affected by COVID than their male counterparts. And then finally, for that slide, more carers as a result of COVID. So more than 10% of respondents in our survey say that they took on caregiving responsibilities as a result of the pandemic. So to summarize, more care, more intense care, and more carers as a result of the pandemic. In terms of access to care services, so both health and social care for carers themselves and their care recipients. First of all, almost half of respondents, a bit under 50%, did benefit from the support of care services before the crisis. So, first of all, key message, not all of them have access to care services. Among those who had access to care services, 1/3 report that those services have been reduced after the outbreak. 1/3 of respondents, again, have experienced difficulties in accessing care services for themselves or for the care recipients. And in terms of the care services most used by carers during the pandemic, that's very interesting from our perspective because that's completely new. Healthcare services comes first, and before social care. And this is interesting because healthcare did not appear on the list before the pandemic. And so I think this is one of the key learnings from the COVID. And the 5 most effective sources of support, when you look at that list, I'm going to mention 2: pharmacists and GPs. And again, that's completely new. And that's the key message for our network, is that clearly the primary care sector, and that was already kind of part of our message before COVID, but I mean, COVID, you know, confirms that the role of primary care is essential in terms of supporting carers and in terms of identifying them and assessing their needs, and maybe referring them to other care services, you know, social care and probably NGOs as well. Next slide, please. So action points, what needs to be done? Well, first of all, the report with all the data I'm mentioning right now is available on our website, and I think the link to the report will be published in the chat box. Well, first of all, very clearly, we need to strengthen the interface between formal and informal care. And as I was saying just a few seconds ago, primary care actors have a key role to play there. We have plenty of promising practices across Europe. You will hear about some of them, in the next few minutes in Scotland, Italy, and Austria. So I'm not going to delve into that now. The second key point is the crucial role played by NGOs, civil society organizations. When it comes to our network, many of our colleagues across Europe, have stepped in and in a way, bridged the emerging gaps suddenly as a result of the crisis by developing new support services, by giving carers access to PPEs, as Matthias was saying, by providing them with information about COVID and about available care services or support measures via helplines, online, phone lines, and so on. By creating self-help groups, and by providing carers with emotional and psychological support, which is extremely important for carers. Now, the key question attached to that, though, is, okay, NGOs are expected to play that role, and we see, a long-lasting trend in that regard, again, which started before the pandemic. But many NGOs, unfortunately, have to work with extremely limited means. So we need to ask ourselves again whether that's sustainable in the long run. Thirdly, the role of ICT-based solutions, so the role of technology to support carers, based on our research, the study. More than 3/4 of respondents have never used care-related technologies. That's one thing. And only 27% of them would be interested in using them. So, yes.
You need to wrap up, Stacey.
Yeah, I'm closing now. Yeah. And so the key thing here is, we keep saying, okay, ICT-based care, that's an option for the future, but there's still a long way to go to make sure everyone has access to them. And then to conclude, obviously supporting carers entails solutions and measures that include health and social care, but beyond that, we also need to look into other policies of relevance to them, such as youth, education, training, and access to employment. And I'll close there, and I'm happy to answer all questions. And sorry for being too long.
Stacey, thank you so much. That was very interesting and I think also extremely informative. And I apologize for the technical glitch, but I think we sorted it in the meantime. I take 4 points from your presentation, and I think each of them is equally important. Number one, and that is very obvious, the pandemic crisis has exacerbated the difficult situation of informal carers, actually. And number two, that came a little bit as a surprise to me. There's a lot of scope for increased integration with health systems, because you are just witnessing that there's actually a decrease in integration and support. And then we saw that, of course, family members are most important in terms of supporting informal members, but already pharmacists came into the pictures, and then GPs. And I think there's a stronger role probably for both of them. I wonder whether there's also a role for nurse. And last but not least, and I think that is my fourth point, there is absolute important role for civil society organization, if you have pointed out, giving voice to these people, structuring this dialogue with health systems, providing tools and all sorts of things. And I think we are going to hear more about this. So Stacey, thanks a lot, and we'll see you later back at the panel discussion. Erica, can you present us the results of the poll?
Absolutely. And Alicia, could you put them up on the screen, please? So, interestingly, most of the people in the audience aren't actually informal carers. Perhaps that's indicative of the kind of people who come to our webinars. But it's an interesting mix of care which is provided in countries, how informal carers are supported, but half of the people here don't actually know what is available. And that's really interesting because this is one of the things that hopefully we're going to find out more about in the three spotlight countries that we've got lined up. We're going to find out more about what we can actually do, what is in place, and what we can actually do to support informal carers. So thank you very much.
Yes, I think the I don't know refers a little bit to the fact that this topic is under-researched actually, and we still don't know enough about it. And also there's, as we have heard from Stacey, not sufficient integration with health systems. So thank you so much, Erica. And this is the moment to ask Claire Cairns from the Coalition of Carers to upload her presentation. Claire, the floor is all yours, please.
Hi, thank you very much. I'm very pleased to be here and talk about the Scottish experience today. So today I'm going to talk about the Scottish experience, but in particular our ongoing campaign in Scotland to have informal carers recognised as equal partners in care, a phrase which we think is really important. And there's a few reasons why we think that's important. Firstly, it defines informal carers as care providers rather than service providers. In Scotland, we argued for a long time that carers shouldn't be viewed as service providers, even though they may receive some support to help them in their caring role. Instead, they should be viewed very much as care providers because of the amount of care they provide, more than the health and social care services combined. So it's really important to view them in that context. Secondly, the phrase equal partners in care signifies the need to involve informal carers in care planning, which again is really key. Unpaid carers bring an awful lot of expertise and experience to the table, which should be really valued. And thirdly, it recognises that informal carers need support to sustain them in the same way as the health and social care workforce does. So for example, in the same way the health and social care workforce has an entitlement to annual leave, so informal carers really need regular breaks from their caring responsibilities as well. So in Scotland, we actually have the phrase partners in care embedded in law. And I'm just going to briefly tell you about 3 pieces of legislation which is built on that development. The first time carers were recognised as partners in care was in 2002 with the Community Care and Health Act in Scotland. And what that also did was it placed a responsibility on health boards both to identify carers and signpost them to local support. And that was a very successful act in terms of increasing the number of carers who are identified, example, through their GPs, etc. Then in 2016, the Scottish Government introduced legislation for the integration of health and social care. And this established integration authorities, which now oversee all of social care, primary health services, and some hospital services as well. And as part of that act, it also increased duties in terms of involving carers in strategic and local planning. And it also gave carers a guaranteed place on integrated joint boards. So again, it was recognising the need to involve carers at the very top of local planning. And then most recently in 2018, Scotland brought the Carers Act became law. And that act is primarily to extend new rights to carers, and also is to provide consistency in terms of the journey that carers need to take to get support locally. But again, it also strengthens the involvement of informal carers as partners in a few ways. It places a duty on local authorities to involve informal carers in the care planning of the people they care for. And it also places a duty on health boards to involve carers in hospital discharge planning. And that's really important for a few reasons. Quite often, whenever you don't involve carers in care planning, you make assumptions about the care that they're willing and able to provide, and that can cause real difficulties for informal carers. So it's important they're involved in those care planning, particularly, I would say, at the point of hospital discharge. So just to give you a little bit of context about the carers movement in Scotland, we've got a very strong carers movement in Scotland. We have 6 national carer organisations, which our organisation is part of. We also have a network of local carer centres in every local authority in Scotland, and they're supported by the national carer organisations. And we have a very close relationship with the Scottish Government as well. So our communication has developed, so it's much now kind of top down, bottom up, which means that during the pandemic, we had an increased level of communication, which allowed us to identify and respond to the needs of informal carers during the pandemic. So some of the measures that have been put in place to support carers are, the very first thing that came out was funding for local carer centres to enable them to purchase technology, which meant they could move all their services online quite rapidly. So there was very little gap in service even at the beginning of the pandemic. The Scottish Government also developed a short break scheme, again through local carer centres, in order to provide carers with small budgets to purchase some form of break. And this was because, like in most countries, a lot of the traditional social care services that carers use either were suspended or stopped altogether during the pandemic, or were drastically reduced. So this funding allowed people to purchase a little bit of support to help them through, for example, employing a relative to support them. And then the Scottish Government also provided an additional payment to Carers Allowance to compensate for the fact that there was increased spending during COVID-19. For example, with people being in the house more, there were heating bills, there was extra shopping bills, etc. So that extra payment helped to compensate for some of those costs. But in actual fact, for most carers, what they've told us is their greatest fear throughout all of this has been contracting COVID-19 and passing it on to the people they care for, most of whom are clinically vulnerable. So because in Scotland, carers have been recognised as partners in care, we were able to argue quite quickly that informal carers required the same safeguards and protections as the paid workforce. So some of the health-related initiatives that came in were, firstly, access to free PPE, which came in quite early in the pandemic, came in about May 2020. Carers can access that through their local carer centres. Informal carers were included in the priority list for testing early on as well. Back whenever it was quite difficult to get tests, they were included in the list along with the health and care workforce. And most recently, informal carers have been included in the list of priority groups for the vaccine. So carers are in group 6 in Scotland, which means that they're alongside people with underlying conditions and before people who are over 60. So the caring population in Scotland who have identified themselves have all been vaccinated at this point, which gives them a great deal of reassurance. So just to round up, 3 things to take away from the Scottish experience. 1, the importance of recognising informal carers as equal partners in care and what that then leads to. 2, the importance of having networks of support for informal carers. That's very often where campaigning starts and where we actually hear from carers about what their needs are. And 3, the importance of health and social care working together and also involving informal carers in service planning to have them around the table, because very often they are the users of services, they know where the deficits are, they know where the challenges are, and also they know what the solutions are. And I'm just going to finish with this slide. You may recognise this phrase. It's been around since about the 80s, very often used within the disability campaigning world. But I just think it sums up in 5 words what I've been trying to say in 5 minutes, which is involve carers, have them around the table, make sure you recognise them as equal partners. Thank you.
Claire, thank you so much. Excellent. It was a great presentation, very impressive. And I think, I hope that during the panel discussion, we have some time to explore how is it possible that you have such good civil society government relations in Scotland. I mean, not all countries in Europe or in the wider European region are appreciating civil society as much apparently as Scotland. I think, they are context conducive actually to civil society engagement in Scotland, which help a lot. Very impressive. Thank you so much.
Thanks.
Let's move to the next speaker, Giovanni Lamura from Italy. Please, Giovanni, the floor is all yours.
I'm happy to be here with you, and I'll try to share my slides to share with you some recent developments in the support of informal carers in Italy. I will quickly go over these figures, which just would like to share with you the fact that Italy is in a kind of intermediate situation like many other Southern and Eastern European countries in terms of informal care provision. These data do not tell us anything about the intensity of care, which is likely to be stronger in these countries, including Italy, although burdening the shoulders of a limited number of carers. What is interesting for us today, and this is, I think, what I'd like to share primarily, is that during the first pandemic wave, the older Italians seem to have been among those most heavily affected by both a drop in the informal care received and by the difficulty of receiving home care. So that's a clear message that in countries like Italy, but that's together with Cyprus, Greece, Hungary, and Israel, this corner of this picture shows countries where there was a dramatic drop in the available informal care and home care provision. This is something which we need to consider to recover in the after-pandemic times. And as far as Italy is concerned, last October, the government agreed on the criteria to implement the fund to support family carers. Actually, this was established in 2007, but not yet put into practice. It's not a major amount of money, only 20 million euros per year, but this was the first time that an official definition of family care was used to allocate resources at national level. And secondly, that priorities were identified for using these funds, such as they would support carers of people with very severe disability and those who could not access residential care due to the pandemic. And that they should primarily facilitate the institutionalizations. Now, these are overall national criteria to be implemented at regional level, and that's why I'm telling you now an example, the one of the Marca region in central Italy, which is on the one hand embracing an overall strategy aimed at strengthening the integration of already existing services by activating a coordination among them. This, again, was already planned since a long time, but never really implemented. On the other hand, the components of the recent law make available an allowance of 1,200 euros per carer. That's for the existing year, to be applied for through single points of access, which will refer requests to integrated assessment units in charge of a multidimensional evaluation of the needs of both care recipients and carers, as well as of drawing up and monitoring a personalized care plan. A care pact between carers and service providers will define and customize support to carers in terms of information, health promotion, respite care, and training. And so-called social health units will supervise the whole process. It looks complicated and ambitious, but my hope is that I will be able to report good news at the end of this year about this, because this process might benefit, and this is my last slide because I know that we are running, may benefit from Italy's National Recovery and Resilience Plan, whose final version, released just 3 weeks ago, surprisingly included, it didn't in the first, in the draft just a few weeks before, the commitment to approve a reform of the country's long-term care system. The good news here is not that this commitment mentions informal care, because it doesn't. But since this promise was obtained thanks to a broad lobbying campaign by a variety of civil society organizations, my hope is the same coalition of forces will be able to make sure that this reform will do include carers. So I shall to keep an eye on these developments, and on this I'd like to thank you for listening.
Giovanni, thank you so much. And actually your presentation fits perfectly into our motto of build back better, because we don't want to go back to the normal. We want to do the better thing. And as I understand, in your region at least, or even in all of Italy, plans have been made for quite a while, but never implemented. And now with the recovery and resilience facility, there is actually an opportunity, a window of opportunity to address this. When I saw an allowance for carers at 1,200 euros per person, I thought, oh my God, what Stacey was telling us about the numbers and what the implications are, that's quite ambitious and quite a lot of money, but very interesting to see, and probably a huge leap forward for integration into health and social services. Thank you so much. And as a last but not least, we would like to invite some of the experience coming from Austria, and Stefania Ilinka from the European Center for Social Welfare Policies and Research is already ready to share the experience.
Thank you very much, Matthias, and good afternoon, everyone. I'm going to take a few minutes to talk about the development of community nursing in Austria. And let me start by mentioning a few forms of support for informal cares throughout the pandemic that were implemented in Austria. These included telephone hotlines, online courses and support materials. There were online support networks organized for carers, signposting services and the like. And I'd like to emphasize here that most of these services, overwhelmingly such services, were provided by long-term care providers with relatively little involvement from primary care or from the healthcare sector side. Now, that being said, there have been nurse-led models in support of informal cares that were running before the pandemic. What characterizes them in Austria is the localized nature of experimentation, the disease-specific nature. For example, home care visits organized by qualified nurses to support carers of people with dementia are an interesting example, but there have also been regional experiments with nurse-led support programs for young carers and families with children carers. Now, aside from the fact that the coverage of such programs was limited, the take-up has unfortunately been modest. And as the pandemic hit, this raised even higher barriers to implementation and limited reach. As a result, I chose to share a quote from an analysis of the system, long-term care and health system performance in Austria during the COVID crisis that says, the crisis has shown that care continues to be characterized by the division between health and social care and between formal and informal care. So once again, a long-standing gap in the health and social care system that has been brought into the spotlight by the pandemic. And the program I want to talk more about today is the community nursing pilot. This is part of an ongoing long-term care reform process that has been discussed in Austria for the past few years. It's already ongoing before the crisis hit. But of course, as the first COVID wave started to affect all European countries, Austria included, implementation was brought to a standstill. In the beginning of this year, piloting preparation resumed, and it was also confirmed that funding has been allocated to implement the pilot through the resilience plan for Austria over the next few years. The goal of the pilot is really very simple: to respond to unmet support needs, improve the well-being, and strengthen self-help capabilities, importantly, of older people and their informal caregivers, very explicitly stated in the goals of the pilot. This is important because it grounds the intervention in a public health and population-based approach to care. The pilot aims to run with 150 community nurses over the next few years, and it's expected to reach approximately 50,000 care users a year. So it's already a large-scale pilot that is expected to make quite a bit of impact. The main roles of the community nurses, and you might be familiar with the models from other European countries who are already implementing such services, are really to facilitate coordination, and importantly, coordination between primary care and home care, so looking at the interface between health and social care systems, but also coordination with informal caregivers. For the first time, a very explicit attempt to bridge the gap and to improve communication at the interface between formal and informal care. There's a focus on prevention, on health literacy, and on health promotion, again, showing the grounding in the public health and in primary care principles for population health. And finally, there's an explicit focus on facilitation of access to information, to advice, to counseling, signposting to relevant services for care users, older people, and their informal caregivers. And there is also an explicit equity orientation with the program aiming to target especially vulnerable and hard-to-reach groups. Here is an overview of the timeline. Already in the third quarter of this year, experimentation, the piloting is planned to start with a smaller cohort of only 50 nurses, but it will be scaled up to its full size. 150 community nurses should be already working by the beginning of 2022. There is an interim evaluation plan in the fourth quarter of 2022. And this is very important because it reflects an understanding of the importance to address uncentralized government and governance in both health and long-term care system. Austria, like other European countries, has a regionalized distribution of responsibilities. So it's understood already as the pilot is being prepared that important adjustments and adaptations need to be made from one region to another. The final evaluation of the pilot is planned to take place and to be presented by the second quarter of 2024. And the end of the pilot is in December 2024. Once again, I appreciate very much, and I'd like to discuss maybe if there is interest, the importance of having a clear evaluation plan as the pilot progresses. I think it shows commitment to scale up. I think it shows commitment to learning the lessons of the pandemic and of the pilot as we move along, and to really develop community nursing into a core service and a very important part of integration across the formal and informal care interface. That's it for me. I'll stop here in the interest of time, and I'm happy to take any questions.
Stefania, thank you so much for this very interesting presentation. And again, apparently the Recovery and Resilience Facility is helpful giving birth to the community nurse. And I can only hope that the community nurse is very well integrated into the primary care units, which are also at the moment developing and rolled out in Austria. And Austria is making their great steps forward. So thank you so much. And I think that is now really time to ask Erika what has come through the chat box. Erika, are there a couple of comments and questions you can feed back to the panelists? So Claire and Giovanni, please join us, and Stacy.
So yes, some really interesting points raised in the chat box. Someone highlighted the experience of Singapore, which might be something that we can follow up later. But one of the important things that colleagues from the Nuffield Trust have brought up was that particularly in England, there's been a narrowing of the eligibility criteria for social care, which has obviously increased the pressure on informal carers. And has this been an issue elsewhere in Europe? Sort of cuts to social care budgets. Has that been an issue anywhere else in Europe? And what can we do about it? Because obviously these cuts have been exacerbated by the pandemic. And a couple of other smaller questions. It's when we're talking about carers as sort of equal partners, what can this mean in practice? What are the practical ways that we can achieve that for people working in the health system? And what's the best way to identify informal carers so that we can actually include them in the process? So thank you very much. Over to you.
Stacey, you may want to start.
Yes, with pleasure. Thanks a million. This is a very interesting and relevant point and question about the narrowing of the offer. This is indeed something we are observing in many European countries, or at least this tendency to shift over responsibilities from professional care services to families more and more. And probably this is something I should have clarified in my message earlier. Obviously, the role of my organization is not to promote informal care as the way forward. You know, the role of my organization is to say informal care is part of the picture, and it should be recognized, but it is not the full picture, and it shouldn't be the full picture. So what should we do about this narrowing? We should make it clear that the foundation of universal care in all European states should be primarily investment in care, in professional care services. And then in addition to that, we need support measures to carers. So what we really need is a combination of things, but in different proportions. And currently, indeed, it is important for us to keep an eye on this shifting, of responsibilities.
Thanks a lot, Stacey. Claire.
Hi, I'm just going to pick up on a couple of those questions.
Yeah.
The one on equal partners in care. How do you do that practically? Well, I suppose just involve carers in each, in every stage and in every part of the health and social care workforce provision. And very practical ways you can do that is if you are assessing the needs of a person with care needs, then ask, is there an informal carer, and involve them in that as well, because most of the time they're providing the majority of care, and what you'll be providing is probably just a small intervention. So make sure you involve them in that conversation, and make sure you involve carers in local care planning as well. I think that's really key. And then just quickly, I wanted to pick up also on identifying carers, how to go about it, who's responsible. So just to say, I would say everybody is responsible in terms of identifying carers. What we find in Scotland is GPs are very often the first people that carers go to when they have a caring role. So it's really important GPs play their role, all health staff, all social care staff, community organisations as well. And I suppose a key point though is if you're identifying a carer, practitioners may be reluctant to do that if they've got nothing to offer them. So once you identify a carer, it's really key if you can signpost them to local support and information. That makes a massive difference.
Thanks, Claire. But it's also clear at the same time that it's getting really complex for informal carers, and that they need really to be part of the multidisciplinary care team and really included in the flow of information. Otherwise, they are running from professional to professional, from doctor to doctor. I think that's very, very important. Giovanni, please.
My observation is that in Italy, actually, the pandemic was an occasion to make the role of informal carers more visible, actually. Probably because we started from a much worse situation in terms of recognition of the role of informal carers in our society. It was visible that the system was not working, and that informal carers were those making things running despite the lack of support from a formal care sector. So it became visible that some form of support was needed. And that's why in October, in the middle of the start of the second pandemic wave, this funds was established, and testing and vaccination included priority lists for carers. So that was probably something unthinkable until a few years ago. And I think in this case, but it's not a sign of, it's a sign of movement, of a dynamic going on, but because the starting point was so low compared to other countries that that's happening.
Giovanni, can I ask you back very, very quickly? Claire's talking about Scotland. Stefania was talking about a pilot in Austria. And we all know that Italy is a very decentralized health system. Is it for all of Italy that these developments are taking place, or is it very regionalized again? Very quickly.
It is very regionalized again. So that's what I described is the general situation. But there are regions in the north where they have much more advanced situations, and that they were also the front runners in terms of fighting for the rights of carers.
Thanks a lot, Giovanni. Stefania.
Yes, picking up on the point Giovanni was making, I also think it's a great opportunity in the aftermath of the pandemic to promote awareness of care work and to promote the value, correct valuing of care work, be it by care professionals or by informal carers. And with respect to sustainability of care systems and formal services being cut, we have now an opportunity to do more to show what the real cost of informal care is. For carers, for societies, for communities, and down the road for care systems as well. And importantly, as the discourse of sustainability will come up inevitably, as the economic effects of the pandemic will become more and more clear, we have to bring out the message that sustainability of long-term care systems means sustainability of informal care. Stacey hinted at that. There is no other way forward. If there is one important intervention to do, that should be supporting informal caregiver. If the propensity to provide informal care and the intensity with which it is provided are reduced significantly over the next years, it would be very, very difficult to compensate with formal care services.
Stefania, thank you so much. And I can see that the question about sustainable health systems financing keeps being very interesting and very complex. Stacey, please wrap up with me the session, just 2 or 3 sentences.
Yeah, I'd say the key word for all participants, hopefully for today, should be partnership. I think carers as partners in care, that this is a very important phrase, not only for Scotland, but for the whole of Europe. Not to create a new realm of activity for informal carers or a new group. You know, carers are already there. They're at the center of the provision of care across Europe. They've been there for, for ages. They need support. They should be recognized. If we don't do that, they will become patients, and so that will add to the issue. That's the first thing I'd like to say. Second thing, building on what you just said, Matthias, regarding the economic arguments, and based on your reaction to Giovanni's slides regarding the financial support, and the statistics I provided. When I gave the figure of the value of informal care between 320 and 368 billion per year, that's not an expenditure, that's a contribution to society. So if you take that into consideration, probably it would be cheaper to actually support carers than to, for them to completely disappear and replace them. So, that's the second thing. And the third and last thing, there's a bigger question, I think, attached to all of this, which is the way we approach care and caring in our societies generally. There's another phrase I very much like, and I think it's used by the WHO, which is health is wealth. Well, care and caring are also wealth and should be recognized as such.
And this is almost a perfect remark to say this will not be the last time we've been talking about informal care, because I think it's a big topic and there are a lot of areas to explore and there's a lot of potential to improve. Thank you so much to all the speakers. That's been great. And for all you attendees, just one thing. Next week's webinar is on administering the vaccine, an optimal mix of professions, settings and priorities to build back better. And the seminar will be about what have we learned from the skill mix, what we want to retain all the health workforce agility. And here comes the fun fact. I was vaccinated by a midwife. So thank you so much and see you back next week. Bye-bye.